Since we've incorporated the Diopsys Nova into our clinical setting, we have found that we are detecting disease processes earlier and earlier, which only benefits patients. We know that glaucoma has a neurologic component to it, just like other neurologic diseases, Alzheimer's, Parkinson's, multiple sclerosis. We know that the earlier that you jump on treatment and get patients treated, they tend to do better in the long run. Well, glaucoma falls right in line with those, and when you're able to treat earlier, long-term outcomes are improved. So the Diopsys Nova has certainly helped us in diagnosing disease states, glaucoma, plaque window toxicity, macular degeneration. At the earliest possible time for that patient, you treat earlier, you educate the patient earlier, and you get a better outcome long term. We have noticed a significant difference in our patient outcomes. It has changed how we do things in our electrophysiology clinic and in other clinics at the Oklahoma College of Optometry since we've got the Diopsys Nova system. We've had a number of patients that we have started on treatment because of the results of this testing and the ability to show the patient an abnormal reading. The problem with visual fields and other testing is the damage is often already done. So by the time that you start treatment and lower their pressure, you're not seeing a reversal of visual field defects. You're not seeing a reversal of OCT defects. What's been really cool and interesting in our clinic is we've been able to show patients an abnormal visual evoked potential, or VEP, an abnormal pattern electroretinogram, or pattern ERG, and we start treatment, and 6 months later, a year later, to show an improvement in that test is outstanding and very exciting for the patient, and it's a great education tool, and it helps with compliance. You're taking your drops, and look what's happened with this better test result. Another case that I have seen in very, very real world is a glaucoma case. We all have those patients where you look at their eyes and you look at their different scans, and you could go either way. Is this glaucoma and I should treat, or is this not glaucoma and I should just monitor? The decision to put patients on drops often is a lifelong decision. They don't take drops for a week in glaucoma. They don't take them for a month in glaucoma, so it is a big decision. So we have many cases where we look at it and go, boy, I could tip either way. Well, now you have another piece of the puzzle, another piece of the pie to do a test and detect, are those cells dysfunctional? How are they functioning? And I've had cases where we had a gentleman who was 62 years old, and we looked at his nerves, we looked at his OCTs, we looked at his visual fields, and we were right in the middle, could go either way. And he told me, he said, Nate, I don't want to start treatment unless I absolutely that I have glaucoma. Well, we did the electrophysiology testing of VEP and a pattern ERG with the Diopsys Nova system, and it red flagged him. Basically, he was showing dysfunction in his visual pathway and his ganglion cell layer on the pattern ERG, and we decided to treat because of that. And he was one of those fortunate patients where when we lowered his pressure, his VEP and his pattern ERG improved. So that was a case where we really jumped on treatment early, and he was very happy at the outcome, and that was a glaucoma case.